So good morning and welcome to the 31st meeting in 2012 of the Finance Committee of the Scottish Parliament. Can everyone present please turn off their mobile phones, tablets, Blackberries, electronic devices, etc. We have received apologies from Jamie Hepburn, who is unwell. However, I'm pleased to see that Dave Thompson is here once again as a substitute. How many times is that now, Dave?
I think this is the second or third.
All right, well, there you go. I'm sure it must be more than that, but you're certainly a welcome addition to the committee when you're here. Okay, the first item on our agenda today is to decide whether to take item 3 and further consideration of a draft budget report in private at future meetings. Are members agreed? Members have indicated agreement. Can I also ask the indulgence of members? I would like members to...
Switch off the phones.
Indeed, Mr Mason. I would like members to agree, if they would, to take the employability report first. We did a lot of the work on that last week, and all we've got to do is go through kind of some paragraphs that we didn't fully agree on, and that gives us much more time to go through in detail the budget report. So, members okay about that? Okay, thank you very much for that. The second item of business today is to take further evidence as part of our inquiry into demographic change and the ageing population. We will take evidence in roundtable format, and can I welcome to the meeting Mr Bob McDougall of Trust Housing Association, Soumen Sengupta, I hope I've pronounced that correctly, of West Dunbartonshire Community Health and Care Partnership, and Michael Thain, City of Edinburgh Council. We are still awaiting 2 guests who unfortunately have not arrived. Now, just for the record, I did make this point last week, but for those present and also for the record, just to remind people that this inquiry is to identify the impacts which demographic change and ageing population will have primarily on the public finances in respect of provision of health and social care, housing and pensions, and the labour force, and the planning being undertaken by the Scottish Government and key public bodies to mitigate such impacts. The committee in its call for evidence asked to what extent are the pressures on health and social care a consequence of an ageing population as opposed to other health challenges such as obesity. So, for example, conditions such as sight loss, thinking skills, diet and nutrition, fragile factors that can have long-term and substantial costs in relation to health and social care, but also in the area of housing. For example, the ability of a person to continue to live in their own home, or what adaptations may be required. Now, just like last week's session, this session will therefore focus on the health and social care and housing aspects of the inquiry, and allow up to 75 minutes for the session. Now, I'm going to ask Michael Thain to start us off on this. He had an excellent submission on behalf of Edinburgh City Council. So, but before I go to him, just to remind everyone that anyone can contribute to any part of the debate or discussion. The only queuing system is when I see you, and if you have spoken, feel free to chip in 2 or 3 minutes later. It's not a kind of, we're not taking people in sequence, so you can contribute as frequently as you wish. So, Michael, your submission, in your detailed and very interesting submission, you highlight the long-term financial plan model adopted by Edinburgh City Council to identify the costs of delivering services and to calculate what savings could be achieved, and that's within a context of a predicted 43% growth in a number of households in Edinburgh. So I'm wondering if you can perhaps talk to us about that 10-year plan, just to kick us off.
No, it's okay. The 10-year plan was introduced in 2009, and it's designed to, I think, give the council a longer-term, more strategic context to making budget decisions. And I think it's in the context of local government, we become very focused on what needs to happen next year. But the purpose of the long-term plan is to ensure that members, officers, the public are aware of longer-term risks when making decisions for the year ahead. So the long-term plan is revised annually. It takes account of demographic issues, but also tries to take account of the other sort of policy and public sort of context within which decisions are made. So issues like rising energy costs for households, the impact of welfare reform, are increasingly part of that part of the long-term financial plan in trying to assess what the impact is of that wider policy context on households, and then what the council has to do to respond and to prioritise within that.
Okay. Now, what was interesting was that Mr Sengupta, in your submission, you said that West Dunbartonshire Council doesn't use demographic projections beyond the 3-year budgeting cycle. And what you've said is that it's fundamental for local government to project spending needs, but there's also a requirement for central government to provide a certain level of information on the same basis, i.e. funding plans over a longer period than 3 years. So I'm just wondering if you wish to comment on that.
Thank you. I think we've sought to learn from the experience of areas such as Edinburgh in terms of what we've been doing, and I think there's two elements to it. Firstly, as the colleague just kind of highlighted, these end up being revised on an annual basis anyway, however long term you end up planning. And the further out you go from the medium to long term, the more uncertainties or assumptions, however you want to define it, you're making. So certainly up till now, we've been taking a very prudent approach in terms of saying, you know what, we could set out something much more longer term, but the reality is the further you got into years 6, 7, 8, 9, there's so many uncertainties that you would effectively have to do something quite radical again after, say, 4 or 5 years' time. So it would be 10 years on paper as opposed to 10 years in practice. That being said, we have had the advantage of seeing what areas like Edinburgh and others have done and how they've been firming up their work. So where we're now at, since this submission was made, is that we've got certainly 5-year plans in place for the authority rather than 3-year ones in terms of our strategic plan and also our financial plan. And we're currently going through the process of developing a 10-year capital plan for the authority in terms of investment decisions that we need to make, very much again in line in terms of thinking about the needs of the population. And that does heavily talk about and consider the impact of demographic change, both in terms of increasing volume and proportion of the older population, 65 plus, but also the 85 plus age group, but also then thinking about the challenges that presents for other cohorts of the population who previously would have been of a higher proportion or higher number, and that's changing. So the kind of obvious examples are then to think about the numbers of schools, your schools estate, etc., quote unquote, versus, in inverted commas, the investment you will need to make in supported housing, accommodation, care homes, aids and adaptation, etc.
Mr Thain, you said in your submission that some £52 million of additional demographic change-related expenditure has been identified within the long-term financial plan. Is that a direct result of actually having produced this? And is that helping Edinburgh Council direct its spending more effectively in the years to come?
What it allows us to do is the submission says it's £52 million over the next 10 years.
Indeed. And
it allows us to be aware of when we're looking for efficiencies in budgets or areas with that require additional resources. It allows us to make decisions if we know that £52 million of additional funding is required over that period. And so it makes it easier to make longer-term policy decisions when we know that there's that additional requirement, and it allows us to see the risks. If, for example, there are proposals for efficiencies in that area, what the risks may be if we're making savings in that sort of area. The other thing that was mentioned is that, as well as the 10-year plan, we also have other plans that go beyond that. For example, in the Housing Revenue Account, we have a 30-year business plan which allows us to make sort of longer-term sort of financial planning as well around debt management and treasury management as well.
Okay, I'm interested as well in the fact that although the impact of demography not being restricted to older people, and what you've said is that over the next 5 years, interestingly, you expect to have to spend £13.4 million more on social care for adults with learning disabilities compared to £10.5 million more on older people. Is that a trend you expect to continue, or is it a kind of medium-term expectation?
I think as you've seen the submission, what we've identified are trends in the area of sort of learning difficulties, trends where people with identified learning difficulties, there's a greater proportion of them being identified to the council services through our assessment processes, and that's been increasing year on year. I think that's an example of a trend where we're projecting existing trends moving forward in that in the area of disabilities, both learning difficulties and physical disabilities, that increasing. The methodology around that, I think, is partly or mostly around predicting continued growth in those areas on the basis of previous trends. As my colleague said, all these things, none of them are an exact science, but it does give you a context. If you regularly review, then you can make those sort of year-to-year budget decisions in the awareness of that knowledge. So in disabilities, we are seeing year on year and have seen year on year increased demand for services from households. We expect that to continue, but the discipline of the long-term financial planning process allows us, if that drops off, to be aware of it as we make decisions.
Okay, thank you. I should say to everyone around the table, we are able to contribute. This isn't just a kind of dialogue between myself and certain of our guests. Gavin?
Maybe a question for all guests and panellists. We've heard, I suppose, various comments about timelines, from looking at things year on year to a 3-year plan, or now a 5-year plan. We've heard of a 10-year plan or a 30-year business plan, I think, in relation to some aspects of the business. Obviously, the longer term view you take, the more strategic you are, but the longer term view, your figures are based on, the less accurate they potentially could turn out to be. Do panellists have a view on what is the optimum amount of time that it is worth doing modelling and projections for? Throw it to anyone, yeah.
52 million you talked about for the 10 years. Can you tell us what kind of proportion that is of Edinburgh's budget, just to set that in context? I know yesterday your grant was increased from 790 to 711 million. I don't know exactly what the Edinburgh City Council's total budget is.
I'll make calculate. I think the budget's just over a billion overall, so it would be in the region of 4 or 5%. Is that right? Yes, if my arithmetic's working there.
Is it not? Is it? Well, it's not really. Is it not? 0.5%.
Yeah,
actually?
0.5%. So in I suppose response to the optimum level, it depends on what you're looking at. So I mentioned, for example, the 30-year business plan we have for council housing, which projects rental income, debt and investment over a long time scale, because the nature of the housing life cycle, you predict it around those things. And I think the discipline of business planning is something that's, over the last 10 years, has become much more common in both council housing and with housing associations. And that gives you an ability to, again, put the context of your decisions over the next 4 or 5 years in the awareness of what you need over the longer term to maintain properties, improve them, and build new homes. And I think that, if you look at in the private sector, commercial sector, that long-term business planning is a discipline that's used quite widely, and certainly in housing that's particularly relevant. In terms of the optimum, I think if the key thing is the awareness that you have of the risks that are involved in the information that you're including in your planning. So you're absolutely right that the longer you plan forward, there are more risks that things will change during that time, because of things in the outside world will change. Also, if you take, for example, our projections on household growth, they're based on projections on household growth are probably more vulnerable to changes than population growth, because a lot more depends on people's behaviour. So if you look at changes in welfare reform, the changes in housing benefit in terms of additional bedrooms and people losing housing benefit because if they're social housing tenants and they have one or more unoccupied bedrooms, may well create significant changes in people's behaviour in terms of how they compose their households. That is difficult to predict until you actually see a major policy change impacting on people. I think the key thing is the longer term you're planning, you are more strategic. But the other aspect of being more strategic is being aware of the risks that are around in terms of predicting that information. And if you're aware of them, you review them accurately. I think it's a sensible discipline.
Okay, John, before that, Jean.
Thanks, Convener. Yes, continuing on the idea of data and projections, I was looking at the Great Glasgow and Clyde health paper, where there's a very interesting table on page 2, paragraph 5, talks about yes, life expectancy and healthy life expectancy, and we've kind of touched on that before. I mean, I'm interested in the table refers to men, obviously. I'm also interested that this table, we seem to have all the women at one end and all the men at the other end. I don't know quite how that happened. But absolutely. So is this quite robust, and can you maybe tell us a little bit more about this, the whole idea of healthy and not healthy life expectancy? Because we've had evidence at committee that in the last year or 18 months, that's when people need most intervention and help. So does that mean if somebody lives 10 years longer, you know, they don't need help for an extra 10 years, or is it more of a kind of gradual thing, or how does it work?
The thing that's very difficult to predict, just building on that earlier discussion about planning. If you're an optimist, you'd say as people's lives lengthen, the period they're healthier will also lengthen. But then you bring into play a series of behaviour issues, the rise in obesity, the rise in alcohol consumption, and the increasing numbers of people we have with long-term conditions with other disabilities that's already been referred to. And then you become more pessimistic, and you could easily argue that people will live longer but will actually have an equivalent period in percentage terms of their lives will be unhealthy. And that's a huge issue for the health service, that there's this expectation that if we can look after older people better in the community, if we can be more innovative about the way we deal with older people, then that will take pressure off the health service, potentially allow a shift in resources. That's partly true because there are a number of older people treated in hospitals or stuck in hospitals who don't need to be. But on the other demand side, if you've got a longer ageing population whose lifestyle choices mean they are unhealthy, then they will put massive demands on the health service for a whole range of services, whether it's cancer services or surgical services, so not necessarily the traditional older people's care that we provide. So I think turning all those things into the mix makes it incredibly difficult to plan beyond a relatively limited horizon, but does allow us to begin to calculate some of the risks and issues and to calibrate our planning more neatly as we go through time.
So just if I could press you on that, so that means you know, if people are living longer, there's going to be a very big difference between a 75-year-old in one area and a 75-year-old in another area.
There is already. I mean, if you take our own board area, there aren't many 75-year-olds in the most deprived parts of our area. It's the other way around. Our 45-year-olds in some of our most deprived populations are the equivalent of 75-year-olds in our other populations. So the way people live, poverty, lifestyle, has a huge impact on their physiological condition as opposed to their age, and it's their physiological condition that determines how much they use the health service, not just the raw age that they happen to be at. So an 80-year-old in Perth probably will use the health service significantly less than a 50-year-old in the East End of Glasgow.
Thanks.
Okay, Jean to be followed by Elaine.
Thank you. I wanted to ask Michael Thain really about integrated services and budgets. Do you, how does that work, and who is involved in the writing of this report, for example, in terms of the health service as well? Do you have any integrated budgets with the health service to deliver services for older people and younger people, really?
I think there are different examples of the integration that's already taken place. I think it was 7-8 years ago we established with the Health Board, the Council established with the Health Board a partnership around community health and other aspects of social care, and appointed a Joint Director of Health and Social Care Services, who reports to the Chief Executive of the Council, but also the Chief Executive of the Health Board. In terms of the integration of budgets, I could come back with a sort of more detailed submission of evidence about where that integration takes place in terms of budgets and decision making. But there are also examples of projects that have been quite innovative in bringing forward that integrated service. I think some of the longer term care facilities that we have, flexible care facilities, which have involved officials from and officers and organisations from quite different disciplines. So if I use the example of grant and flexible care, Elizabeth McGuinness Court, where it was developed by a housing association with grant funding from the council in terms of the capital side, funding from the health board and from the council's own health and social work services to provide the revenue support and things to keep that sort of viable. I think it's a state-of-the-art facility, but only able to be brought together because of the sort of joint working and integration between different parts of not just local authority and the health board, but other agencies outside, like housing associations.
I wonder if I could comment.
Yes.
Thanks for the invitation. Being here today, just to make general comment relating to some of the points that have been raised already in terms of the planning cycle looking ahead. I mean, from a housing association perspective, we are duty bound to prepare 30-year planning proposals. But I have to say, when you look ahead 30 years, it really is a finger in the air in terms of what the expectations might be. And more realistically for us is a 5-year planning cycle. And interestingly, in terms of the debate that we've had thus far about the strategic approach from local authorities in that planning cycle, the 3 organisations I represent today represent probably about 10 to 11,000 units across the breadth of Scotland, from north to south, east to west, and we work in all 32 local authority areas. And what we find absolutely consistent is the lack of consistency, because it's not inconsistency exists everywhere, and there's not a strategic view taken everywhere. And part of the difficulties for us is feeding into those services in a way which is meaningful. Because Edinburgh's a good example who have taken a very strategic approach to it, and we've fitted in with that. But we find it difficult to fit housing within the context of the integration agenda. And one of the key issues for us is the debate around social care and health and integration debate where housing is not at the table. Now, you may say, well, that's us trying to come along to the big boys and say, it's your ball, give us a game. But it's more than that, because our consistent argument is one of saying, if you're really talking about keeping people out of the healthcare system who shouldn't be there because it's inappropriate for them, we could do much more in the community to meet their needs if we could coordinate services better. There is an argument that says housing is within the third sector, so therefore that's your route into the change fund. But our fundamental premise is one of saying that housing is so fundamental to people's well-being and their health that if you don't get it right, your problem starts there. If you do get it right, then you put in place the building blocks of a just and fairer society, and it helps health service and it helps social care.
Do you want to comment again before I let Elaine in?
Well, I think integrated services is something that everybody has at least paid lip service to, and I'm really just anxious to know what people's experiences been actually making that work, because there's always resistance in a sense to either giving up budget or sharing it, or even in case of Highland, people shifting the organisation they work for in order to make this work, in terms of having been health service employees becoming council employees. So I really just wanted a feel for that from everybody else, and I thank you for your response in terms of housing. And in each of the reports, I think it highlights that housing, social care, the third sector, council and NHS should all be involved. And it's just to get a feel for how that really works.
Soumen?
On Western Dunbartonshire Community Health and Care Partnership is an established existing integrated arrangement, so that might be helpful in terms of some of your questions. I think there's 2 points I'd like to pick up on. Your earlier one was around integrated budgets. We, like other areas, don't have a pooled arrangement. All the money doesn't go into a pot at this point and lose its identity, although that is part of the Scottish Government's proposal in terms of the anticipated legislation. But what we have is aligned budgets. So under the director of the CHCP, who is accountable both to the chief executive of the council and the NHS Health Board, he's responsible for the totality of resource that's allocated for social work and social care within the council and community health care services by the NHS board. And all the heads of service, myself included, have responsibility effectively for two sets of budgets in parallel, as well as staff who are on different employment contracts. And we make it work. I think once you make sure people are quite clear that actually the common purpose we're in the business of delivering for are for our, whether you want to call them clients or patients, our local residents, and an emphasis on a common set of values around quality, provision and improvement, then people can work together. It fundamentally requires a willingness on the side of the partners, both in terms of a corporate level amongst the agencies and including critically the leadership of the elected members to create the body within which this can work, and then effectively the management working closely with operational staff, clinical staff, professional groups, professional social workers, etc., to make it work. From a financial perspective, though, although it is very irritating having to effectively manage two ledgers in your head in parallel constantly, the key thing is that it's the same head of service who's responsible for both budgets. So you don't cost shunt between the council and the NHS, because all you're doing is moving one headache from the left side of your brain to the right side of your brain, or vice versa. So you're able to plan and develop comprehensively. And indeed, we have a number of our service managers at the level down, if you like, are also integrated in terms of joint teams, joint posts, etc. Now, we've done that across both our older people services, the rest of our adult services, learning disability, addiction services, mental health, but also our children's services. Now, they're at a different point, not least because of the policy context, but again, from our perspective, and we've submitted this to the Scottish Government as part of the consultation for integrated partnerships, that's why we very strongly view that integrated partnerships should be period across all care groups. Because it then ties into the earlier points around thinking about the population as a whole and your communities as a whole. So if you're planning for children and families by definition are adults. If you're talking about older people and the caring responsibilities, the people often caring for their elderly relatives are also parents. So you don't make effectively artificial distinctions in terms of your population and the dynamic set of needs within them. In terms of the housing component, and I think our colleague makes a very valid point, I suspect from a very practical perspective, what we're talking about here isn't just partnership in a vague sense of people just coming together and chatting through an issue. It's about the actual delivery and investment in services and it's making hard choices. Effectively integrating responsibilities, the governance, is tricky stuff, as we've kind of seen across Scotland. It's very ambitious work. Certainly that's why it's been talked across around the UK as the model to go for, but it's hard. From our perspective then, the primary links for us are around the over and above the health and social care crucible. It's the relationships within the council, in particular in relation to educational services, and that relates obviously to the children and young people's agenda, and then housing services. The guidance around older people's commissioning strategies, which are out there, very much talks about those becoming increasingly joint documents across both the NHS, social care services, and housing departments. Now, we work closely with Arran area. I'm sure third sector housing colleagues might take a slightly different view on how successful it is, but we understand the role of the third sector and other bodies in interest in housing, but we seek to work with that to our housing department colleagues as opposed to replicating parallel lines of engagement. And one of the tricks in relation to the Change Fund in particular is that, and I think you're right, the issue around the Change Fund, it can be perceived to be a magic bullet for this. But if you think about all the stakeholders around the average local Change Fund implementation table, it's a much bigger meeting than this, trying to represent every single interest. Now, in terms of strategic decision making, whether it be short, medium or long term, and indeed a lot of our challenge in terms of the older population are actually short to medium term. They're about what we'll do in 2015, 2016. You know, there are the challenge for 2025 onward, but we've got some immediate challenges right here and now about the demands around demographic change. You've got huge tables to contend with, and that then brings a lot of challenge around how you make strong, robust, clear decision making when you have such a multitude of voices.
Thank you. Elaine, to be followed by Catriona. Elaine.
Thanks. Yes, I think Bob McDougall's touched on some of the issues which I was hoping to raise, because it really is about where housing lies within that. We know that investment in housing and adaptations, or appropriate housing for older people, can keep people independent. That can save money from social services departments because they're not having to put as much care in. It can save money for the health service because people are not presenting as emergency admissions. But I think in your submission, the Bill Hanford Trust submission, you're saying the crucial that you address who pays for what, when, and how. And that really, is, I think. No, it's not just about how people talk to each other. It's actually how the budgets are set up. And equally, do housing associations have sufficient access to change funds in order to be able to make those sorts of changes? And I noticed also in your submission you make the point that we become a bit fixated, and possibly all of us in this place become a bit fixated on the number of units that we're producing, rather than looking actually at the types of properties that we're actually supporting or bringing back into use, and whether or not those are suitable for older and disabled people.
In our submission, what we were actually saying was, I think there's a need for a better shared understanding of what we can do. I think the point was made earlier by Dean Erskott's absolutely right, that there is no new money. And I think the trick is, how do we use the existing resources in a better way to get a better result for what's there? And I think our argument would be one of saying that you can look at the mix of how those resources are distributed in a different way. Because, for example, there is a natural tendency to say we need to build new houses, and we do. Our argument would be there's a lot of the existing housing stock out there at the moment which is not being used properly. And although there are huge pressures out there and huge challenges, there are huge opportunities as well, I would suggest, in terms of being able to use the existing stock we have in a better way. It's interesting, for example, that in the broadest sense, the use of sheltered housing in Scotland is reducing because of funding pressures. And we're seeing, and Michael alluded to it in his evidence, we're seeing more specialised types of housing with care models coming in, and we provide some of that as well. So my argument consistently for the last wee while has been the middle ground, if you like, in some ways, is being squeezed, where people are moving out of the traditional housing, sheltered housing sector, and moving towards a more retirement model where people are paying for their own support. And on the other hand, they're moving to a more intensive care, and the middle ground's been left. And there's an opportunity there, if we can get the funding better balanced, in my view, to actually engage with social and healthcare colleagues and say we can use the existing resources better by investing in that middle ground, using the existing stock we've got better, refurbish it and provide additional services to those people in the community, and try and stop this situation where a lot of people end up in the care system because of age, not because of infirmity. And we have bed block. If I had £1 for the number of times that people in the health service have came to me and said, Mrs. Smith's coming home from hospital next week, is that okay? And I'm saying, well, wait a minute, it'll take 3 months to sort our housing problems out. So it's bed block for 3 months until we do something. And it's so basic. And we've got an AIDS and adaptations budget nationally, which was 10 million cut to 8. The proposal was to cut that to 6 million again, and we produced evidence through the SROI that we produced on adaptations, which said, actually, if you look at the value for money that produces, that's a budget that should be expanded, not cut. Now, full praise to the government for doing it. They said, OK, we won't cut it. And they kept it at 8 million. But there's a strong argument, I would suggest, for expanding that. It's very basic, very simple, straightforward stuff, but it's very, very cost effective. And there is a huge potential to help people stay in their own homes and save the public services vast amounts of money, because most people want to stay at home. The problem is, a lot of them are getting so old and so infirm, they need help to have that home adapted to allow them to remain there.
Catriona, I'm sorry you weren't here for the start of the session, because I was actually going to start off with your own submission. And you say in it that the immediate pressures of demographic change will make it difficult to fund and support other priority areas with longer-term benefit. And then you say, by extending current models of healthcare to more older people with long-term conditions, it is unlikely we can realise aspirations to shift resource to preventative spend at early years, and that the annual budget should give due regard to other policy priorities, including early years and preventive spend, which may have more significant long-term benefits and are essential to the future sustainability and affordability of services. And I think we would all around the table agree with this, but the issue, of course, is how do we strike the balance in the current economic climate, and how do we address demographic change while investing in preventative spend?
And if I knew the answer to that, that is the challenge. And I think, to say 2 or 3 things, I did want to pick up on the housing issue, because I think it's actually one of the most fundamental failures of planning around the care of older and disabled people that we have. Because I've been working in planning, health and community care for about 15 years, and we have never cracked properly planning housing with housing providers, with the housing finances that councils hold, in a way that matches the predictable needs. And there are many people who end up in care homes or indeed in hospital because we can't deliver innovative housing solutions that bring together a housing solution with a care solution. So I'm not sure that the avenue of people staying in their own homes is viable. I think it's more about people being able to make incremental choices as they need more care for different models of housing, with some care that is before they end up in nursing homes. So I just wanted to say that, because I do think, and I think it's important not to be distracted by the integration of services around the planning of housing, because the integration of planning is different from the integration of health and social care service delivery. And to me, the issue we need to crack is how planning for housing is integrated across Scotland in a consistent way, and that we build on the examples that are best. I don't think it matters whether housing's in the partnerships in that sense. I think it's really important that the planning of housing is part of the responsibility of health and social care partnerships. I'm not trying to duck your question, however, I just wanted to endorse those points. The challenge for us is that you've got a series of kind of pressures on the health service. You've got a whole series of new treatments that come in every year, and that governments are always keen to see delivered because there's public demand for them. So I could come up with 10 or 15 things over the last 5 years that have been introduced that have had significant extra costs that are new innovations. So nothing stands still. People want shorter waiting times. That's a government priority as well, quite rightly. And it's transformed the way healthcare has been delivered from when I started in the health service, when people routinely waited 5 or 6 or 7 years to get a hip replaced, which was not acceptable. And then you've got the pressures of demographics and older people, and quality around older people as well. I mean, one of the issues around all of this is not just doing more of the same, it's the demands people of our age will make when we're older, and they will be different demands than the standard that is accepted by older people now, which is very often relatively cheap institutional care, because it is actually relatively cheap to put people in nursing or care homes rather than provide them with better community packages, very extensive community packages, or very high quality residential care of different types. So I think the point we're making in our statement is that whole series of demands is very difficult to manage, and what is dangerous is a simplistic answer in one part of demand that says, well, if older people use the health service less, there'd be a wodge of cash that we could take out of the health service to fund different services in the community or different forms of housing or whatever. And I think if we see that easy route out in the next 3 to 5 to 10 years, we will be in real difficulty, because it ignores a whole series of other demands on the health service that are becoming more and more difficult for us to deal with as well, with the current state of public finances. Soumen's mentioned children. I think it is important to mention children, because if we actually did more right for 0 to 3-year-olds, then you would over time reduce demands for healthcare and indeed for social care and indeed for the police and indeed the criminal justice system. And there's a lot of talk about early years collaboratives, a quantum shift to prevention. It's actually extraordinarily difficult to deliver, because there is a 10-year period or a 15-year period when that preventative spending does not yet have its effect on other costs. So I think the complexity of all of this planning and all of these demand issues is really very difficult to come up with a very simple answer to. And I think the real answer is there is no simple answer, and the complexity needs to be acknowledged and become a focus for all public bodies to try and work their way through in a collective planning sense.
What I find interesting is in your submission you say that recent evidence from the telehealth projects in England do not provide definitive evidence of cost effectiveness in terms of, for example, reducing demand on older people's services. But interestingly, Ayrshire and Arran say telecare and telehealth are now being seen as essential elements in the equation of supporting people in their own homes with the emergence of more sophisticated technologies. Telecare services reduce the cost of unplanned hospital admissions and delayed discharges. So I'm just intrigued that Ayrshire and Arran and Glasgow seem to have different. I'll let you in a wee minute to talk about that, but I just wonder if you can comment on that.
It's back to that issue that my earlier point about simple banner headline solutions are not going to answer these problems. Yes, for the health service, telehealth works for certain people with certain chronic diseases. It's been really effective in looking at people with COPD and how they're dealt with. It works for people with forms of dementia where social care type telehealth or facilities can actually allow them to continue to live at home safely. But it isn't the big answer to the whole set of problems that we're discussing here. And in our view, we're an urban population, so obviously we have a different perspective for more rural areas where telehealth may have a larger part to play. It is not a solution to the pressure on the health service, particularly as people become more frail, more people live on their own, and if they need care, telehealth can't actually deliver it. If somebody needs help to go to the toilet at midnight, telehealth is not going to deliver that for them. They need somebody, a physical person, to come and help them. And I think that's where you bridge back into housing and forms of housing which are disaggregated forms of housing, not care homes, but with care for people, which may be triggered by a telecom solution, but you still need a body to go and help somebody who needs a body.
Hold on a second. Marlene, because I'm mentioning this particular issue, I was wanting you to come in because there's a contrast between what the two health boards are saying. And the committee has taken considerable evidence over the last couple of years which say there's about 1.5 billion in unplanned admissions, and it seems from the submission, if I'm picking up correctly, from Ayrshire and Arran, which is of course my own area, although many of my constituents go to Glasgow too, that you see this as having a very positive contribution to make.
I think we do have a rural-urban mix in Ayrshire and Arran, and the costs for providing care to people who live in rural areas who also may have housing that isn't appropriate, or quite a lot of rural poverty, difficulty in transport issues, that the telehealth care works for that peripheral sort of population. Because I think there are additional costs to trying to care for people who are, say, have high dependency needs and live away from centres of population. And there are a higher proportion of older people living in rural areas in Scotland, and I think Highland would agree with that. There are less young people as well.
Okay. Now, Bob, did you want to comment on what had been said? Because I was wanting to let John and then...
I was just going to add to the comments that were made to say I think telecare is a vital and increasingly important aspect of services that we provide. My only comment I was going to add was a word of caution, in the sense of saying there's a great attraction to organisations, because what it does in the first instance is allows staff resources to be reduced, in the sense that you don't need overnight cover in some cases because you've got telecare there, so you've got that warning system. But if you ask the customer base how they view that, they would see it as a diminution in services in many cases, because that very fact that the personal input is reduced, because what it does is it provides that immediacy and it calls someone out, but you don't have somebody on standby that you maybe had before, so it's cost effective. It can give you greater coverage, but it comes at a cost. And a lot of these things, that's the bottom line for it. It's the lack of, or the reduction of human contact in terms of the services that are being provided.
Yes, I know that from the withdrawal of warden services in some
yeah, the same sort of thing.
In recent years, people felt that it wasn't just the fact that someone had to wait for someone to come out, it was someone different they didn't know, whereas there was a warden that they know and trust, etc.
With respect, Convener, that's an important aspect of it, because a large part of what we're talking about just now is about using money differently. Certainly, that's key, but it is a bit a fundamental cultural shift in terms of attitudes as well. And we need to get the message out to the customer base about how things are changing, because there's an expectation there of what can be provided, and I think there's a job to be had in information and advice and trying to get the message out to people about what can be afforded, because we can't do everything that people would aspire.
Indeed. Now it'll be John, to be followed by Michael Thain.
Thanks, Convener. Yes, following on the, I think on the housing and the health interaction, I mean, I'm very impressed with both Trust and Beeld have facilities in my constituency, which I think are great, and it strikes me they are appropriate for certain people, obviously nothing's appropriate for everybody. So I was a wee bit surprised in paragraph 9 of your submission, where it says, where possible, this should be through adapting their current home rather than downsizing or seeking specialist housing, because actually I think there are some people staying in their own homes who would be better downsizing. For example, they can't afford to heat the house because it's so big, or moving in. Now, you also say further down, funding streams should be identified, which is a good phrase, in that everybody wants more money, but nobody wants to suggest where it should come from. And, I mean, I just wonder if that links in with health, because presumably if preventative spending is a success, then we end up closing hospitals. But when the health service suggests closing a hospital, all the politicians jump up and down and say they don't want the hospital closed. So how do we kind of cross that bridge? And I mean, I was interested too in Catriona Renfrew, some of her comments about it's not just one size fits all and the idea of being at home, because I think I saw a film this week, which I believe Jean Urquhart has also seen, a French film called Amour, which is about an older couple, and they try desperately to cope at home. And without giving away the whole film, I think the reality...
Because we're not going to rush to see it.
Well, I would highly recommend it, because it touches on a lot of these issues, and they make a commitment that she is not going into care. And yet, as the film progresses, I became increasingly convinced that coping at home was just not the best way for them. And how do we bridge that one as well, to get the best for people rather than just what is the norm or the fashion or whatever?
I think there's just, for me, and I'm not a housing expert, so I'll defer if I get this wrong. There is a gap of not hugely adapted or particularly fancy housing, but a kind of core and cluster model, which we've used for mental health, where you have a pool of staff who are looking after people with high care needs in a core service, but around that there is other accommodation, a range of other accommodation that those staff also support people in, but they're still in effect living in something much closer to their own home than a care home. And I think part of the resistance for older people of going into care homes is it's an extreme institutional solution to what maybe actually be problems that they have where they need care with short notice but not necessarily a huge amount of care. And our biggest problem is if somebody needs care within 15 or 20 minutes but they live in their own house, out of hours 7 days a week, that's very difficult to provide in an unplanned way. So you end up with people potentially in an extreme solution with 24/7 on-site care because there isn't a full range of options in the middle for people. And a lot of older people are resistant to going into nursing homes. It's not seen as a high-quality environment. It's often not a high-quality environment. We have, across the public sector, squeezed the price of nursing home care through national negotiations. And I think there's an argument to be made that it's now not actually well enough funded to give people the quality of care that they need, particularly people with dementia who need more time spent with them and don't just have physical needs. They actually need high levels of care in terms of human interaction to manage their dementia.
What I would advocate is a multiplicity of choice, because the bland statement of saying we should aim to support people in their own home at all costs is wrong. Because you're quite right to say that not everybody can be supported in their own home, nor indeed should they be, because sometimes saying that is to condemn people to isolation and loneliness, because they're not getting the support they need. And what we actually need is a variety of choice. And I think what I'm advocating is that there's a disconnect in some ways between the housing profession and healthcare, or particularly healthcare colleagues, where when we do engage in detail, very often you can see the light bulb going on in health saying, I didn't realise that could happen, this could be a possible solution. I mean, the types of things that we would advocate is we provide the models that are being described where, for example, we have housing with care, as we describe it, where someone will be provided with accommodation, but over and above that, they'll have a meal service, which is hugely important. But we also have staff on site who will do medication and look after and provide low-level cares and support. I mean, small nursing issues as well. But there are different models being developed all the time where there are other services being provided from that source. So you've got the core and cluster kind of services that are being provided about. And it's not beyond the wit of us to develop those services further in a more meaningful way on a local basis. And it's about to my mind, about looking at how existing resources are used and saying, can we do it differently? And where is the evidence to say that's going to be cost effective? You know, I was asked about the response that we made there about the use of the existing housing stock. The SROI that we did on adaptations and very sheltered housing actually produced the evidence to say it was cost effective. It seems to me it's about looking at existing health budgets, for example, and saying, if you take something out of there, it's going to, something else that has to stop. Can you use that? Can you spend that money differently? And can you quickly get the evidence back to say, is it effective before you spend any more on it? Because you have to make sure you're getting value for money, because we don't have additional money. So it's about using the existing resources in a different way. But the key to that, I think, is for people to understand what's available. And at the moment, I don't think we do that in a very effective way. I think professionals don't share with each other what's available in the best way and the best use of public resources overall. And I'll hold my hand up and say, we're not good at that. I'm going to shut up. But next year, 2013, the big challenge for us is engaging with health professionals and getting our message out to them. And that's what we're aiming to do.
Michael Thain to follow by Michael McMillan.
I think just to add to this debate about what we do with existing homes, how we help people move when their home is no longer suitable, whether it's a care home or to a better home that's already there, but also how we plan for household growth, and the majority of that being among the elderly population. Some of the fundamentals of that is that we need new homes. And I think important to that is that, going back to your point about what do we spend on adaptations in existing homes, to me there's a limit, there's almost a finite to what we can do with existing homes, because they were never designed to deal with this growth in older population. And this is when so the value of long-term looking back and looking forward comes in. Because most homes, certainly in Edinburgh, were built before the Second World War. We've got 70% of them are in flats. So they're old, not designed for the sort of energy costs increases that we're seeing, or the sort of older, more frailer population. And I think it's as well as considering the adaptation of existing stock, we need to think about the impact of rising energy costs over the next 10, 20 years on, as household growth is dominated by older people. If we make the assumption that incomes are going down, energy costs have a big impact. So as energy costs increase, there's a limit to what you can do with existing homes in terms of improving energy efficiency, putting in new housing systems. And some of the solution does come down to new housing, which tends to be more energy efficient, better heating systems, and much more flexible when it comes to dealing with people's changing needs in their own home. And I think that's part of the fundamental challenge in dealing with that, is in dealing with new housing, both in terms of the market and for social housing providers, is how we fund that. Because fundamentally, the levels of capital subsidy that goes in to fund new social housing is been decreasing for a while now. It will continue to decrease. The capital subsidy is not there unless you take it away from, I don't know, building schools or building hospitals. So we need to find other ways of funding new housing and new rented housing, because the market isn't supporting home ownership either. So mortgages and things aren't there. So there's an issue there about new housing as well, and finding ways of investing in new housing to help people move and to cater over that next 20, 30 years for that growing level of household growth among older people. It's an issue about fuel poverty as well as about adaptations as well.
Thank you, Michael.
It's going back to the point, because I bang on about this every time we discuss this issue, but John Mason's already touched on it, and Mr McDougall commented also when he said that what we need is a fundamental cultural shift, and I think that's absolutely right. And everyone that's been talking has been talking about the long-term, planning ahead, trying to envisage what's going to be required in the longer term. But when it comes to implementation, we're not allowing the space and the time for that cultural shift to develop, for the ideas to percolate, and for people to be given the space to actually deliver in the longer term, because the next day's newspaper headline is much more important, or the the cost of implementing something is an immediate issue when it needs to be considered in the longer term. And even when we talk about integration and you get the health officials, housing officials, social work officials coming together to look at the statistics, look at the data that's available to project ahead, that when it comes to rolling out the programmes to take us forward to that point, there's interventions from politicians and others to say, well, yeah, we like that bit of it, but not that bit of it, and you actually start to pick it apart. So we never actually get to the point that when we have sat down and said, well, how are things going to be in 10 years? Within a year, the plan has already started to collapse because certain bits of it have not been implemented or they've not been taken forward at the same pace. And it's the idea of this cultural shift, convener, that I've been trying to focus on through all of this discussion. We really need to get away from the short-termism so that when we do talk about these things and we do plan for the longer term, people have to buy in, and there has to be support for that. Now, there will be obviously discussions and deliberations around how to implement those plans, but at least if we can agree that the longer term picture is the one that's the more important one, then at least we've got a starting point that could take us forward.
I think what's interesting is that both John and Michael have talked to us about politicians as if they are not politicians. I mean, that's us. Understand. Soumen.
Thank you for that. To pick up on a number of points, it was something that Murray touched upon, and then John Mason had that, but you couldn't capture it in terms of it just happened to be on your submission, but I think it applies to all of us around funding streams have to be identified. Fundamental, and it's totally appropriate given this is the Finance Committee, there's less money in the kitty than there was before for a range of issues, not least because of the overall financial climate that we're in, and we're looking to see for the few years. So the issue would be, where does this money come from? If we can spend more on X, why do we not spend on Y? If we're going to receive a benefit, Catriona says, in terms of the preventative agenda that we have to be pushing forward with, particularly in terms of the 0 to 5 year age, 0 to 3 age group, but we're not going to see the benefits of that for a while down the road, who's going to sacrifice? Who's going to lose out on something right now, given all the demands and pressures that we have right now, and also the point that you mentioned around the demands to deliver. If I even just look at the Change Fund or any number of initiatives, even though when we talk about medium to long-term programmes, it's about, and in 6 months you'll have achieved X change. And if you haven't achieved that improvement within 6 months, then there's a lot more scrutiny and a lot more intense. And again, I've been a public servant for more years than I care to remember now, so I understand the deal on that. I understand the kind of effectively the social contract in terms of how we operate, but it does make it quite difficult, particularly again that complexity that Catriona mentioned earlier and all the uncertainties. There are no magic bullets, so it is about how we get the space. And I do think it's that point that you both mentioned, which is around the leadership, around the debate. I think I would certainly agree with Bob in terms of what we need to do is think about the demands and expectations people have nowadays will be different when, for all the people in 10 years' time will have a different view of the world. I'll have a different view of the world when I'm 65 than my dad does. How do we engage a responsible discussion with people about how their world is changing, what the opportunities will be, how the things might look better, but also the challenges around, what your parents got or your grandparents got isn't what this is about anymore. And that for me is really the big challenge, because that then goes into, well, that's why if you're talking about housing changes and the kind of cluster models, for example, fundamentally, even if we work out who's going to pay for that, how we're going to design it, people still have to want to move into that. Choice costs. The more diversity of choice you have on the table, the more you've got to invest in providing that and the opportunity for people to exercise choice. But people also have to want to move on from what they've had before, which means be unsustainable, into something new. And it's telling in terms of that point around the film you were mentioning, where that appears to be the crux of the issue within it, that people don't want in it. They're used to what they've got, they like what they've got, they're comforted by what they've got. It fits in with their worldview and their sense of self and identity. But the bottom line is they need to make a shift. And even if it's about not making a shift into a care home, into another type of housing, downsizing, that's a big psychological leap for lots of people to make. And how do we engender a cultural shift where that is just part of what we do and how we live?
Yes, I think we all know the challenges, it's solutions we're really looking for, and I want to touch on some of Bob's submission for a wee minute here. Bob, in your submission you said Scotland currently spends around 4 times more on emergency admissions to hospitals for the over 70s than the entire free personal nursing care budget. And you say, we believe that the government could do much more to increase resilience at community level to avoid unnecessary hospitalisation and relieving bed blocking. In this respect, housing needs to be given a more prominent role in the development and delivery of local change fund plans. Now, you have given us some detail on that, but I'm just wondering if you can give us some more for the record on how you think we can go forward in terms of this.
I think it's back to this point about, I think Catriona touched on it as well, does housing need to be at the planning stage and at the table? And I would advocate, yes, it does. And it's not just about banning the table, it's about being effective. I mean, the point that was just been made already, and Michael McMillan touched on it in terms of the cultural challenge that's there. I know it's going to sound hugely simplistic, but from my perspective, the whole issue around the best use of resources is about power and control. And it's about getting people willing to look at budgets and say, well, that's my budget, and I'm willing to put that into the pot and allow someone else to control it and give that power away. And it might seem very simple and very fundamental and a bit idealistic, but I think that is the essence of it. And it's about the housing sector bringing to the table its expertise and its budget, along with health and social care, putting that in and saying, right, the people round this table will forget their former professional loyalties and tribalism, and will deal with this in an entirely independent way and use that resource to get a different outcome for the citizens of this country. Because if you think about it, we're looking at it from a discipline-led approach where we say a housing perspective, a social care perspective, a health perspective. And I'm advocating that comes into a funnel at some point, and then you get an outcome which forgets those professional barriers. Because if you look at it from the customer perspective, their argument would be, I don't really care who's chapping the door, whether it's the GP service or whether it's from the health or whether it's from social care, whether it's from housing. I'd like my needs met. They're less cared about the label rather than the solution. I think the challenge for us as professionals is to match that same aspiration, is to forget the tribalism, forget about the professionalism, and maybe you say it ain't going to work, there's too much politics involved in it. I think that's a real challenge. I think it's about taking what you've got, mixing it up differently. Any system, no matter how good it is, won't be worked unless people are committed to it. Conversely, the worst systems in the world will operate well if you get the right people. If we can get the right people engaged with that freedom to operate and do the best result and forget what's gone before, I think there's a chance to do it differently.
Thank you. Catriona, to be followed by Marlene.
The integration of health and social care is the thing that changes the whole dynamic around this, because if you take the example of housing, the failure to plan housing properly has a massive impact on the health service, but the health service without integration doesn't have a direct relationship or role in the planning of housing. When you bring health and social care together, you bring together, if you like, the consequences of poor housing planning on an integrated budget. And that is a huge change. I think people underestimate sometimes the scale of that change, because if you're a committee of councillors and non-executives, if you're a director of a partnerships that is responsible for costs in health and social care, including some of the costs in the acute sector, then you have a massive incentive to plan housing properly, which isn't there at the moment, because when housing isn't well planned, the consequences fall generally on the health service in terms of delayed discharge and unnecessary admissions. But the accountability and the role for housing planning doesn't lie with the health service. So I think the integration of health and social care and the focus of those new partnerships on the way the people they're responsible for use acute care is a game-changing dynamic that will make a very big difference if it's done properly, and if it's done in a way that has been set out, whether it's from the Christie Commission, whether it was in Labour policy or whether it's in the government policy, the direction is the same, and it is a fundamental shift in the way that we do business. It won't solve all of the problems we're talking about, but it will solve some of them. I think your point about short-termism is interesting. One of the reasons our housing planning is so problematic is it's the only kind of real long-term planning we do, because long-term service planning, you can change it again year on year, but when you build houses and you commit capital and you borrow it from the banks, you really have to get it right. And I think that's one of the challenges that we've not been able to live up to, because it is real bricks and mortar, real decisions being made in a way that the kind of planning I do or the kind of planning councils do about services doesn't tie you in the same way for the same length of time. So you can take more risks, or you can plan in a more short-term basis because you're not actually tied into it.
If we were talking around the table about housing input, people would have in their own mind about a public sector housing input. I'm talking about housing in the broadest sense, and that includes the private sector. And it's quite a different animal, because trying to engage the private sector in the housing solution that we're talking about, integrating services, is quite different, because they're going to say, well, where's the profit margin in this? If you want to build housing in a different way and you want better space standards, are we going to get that sold on the market? And there's a disconnect in social public policy as well, because we have a drive towards providing better housing, Michael's point, better housing, better suited, better space standards perhaps, with more rooms, and at the same time a changing benefit system that says we'll drive the cost down because you'll be penalised if you've got too much excess space. So there's competing social policy drivers there as well. But I do go back to my fundamental point. Housing, it's been said continually, is a fundamental aspect of good health care and social policy for the future. The housing professionals need to be part of the agenda to offer the best expertise to influence that planning model.
And I think what is interesting is that certainly in Ayrshire and Arran's submission, they pointed out that in North Ayrshire, where I'm an MSP, 2/3 of older people are actually in private housing. So therefore, it isn't just about local authority, or other social providers. The older people in private housing have to be thought of and considered as well. And that brings me neatly on to yourself, Marlene.
I think that there's, in terms of the highest owner-occupier for is in older people in North Ayrshire. I think it might have been the social-oriented sector being bought up, and that could leave people sort of asset-rich but cash-poor. And when we looked at fuel poverty in Ayrshire and Arran, it was clearly the people over 65 who were almost twice as likely to be in fuel poverty as families with young children. So the utility or the heat or eat issues would limit people's ability to remain independent and healthy and in their own home. So there are issues around that, particularly in the 15% most deprived areas of Ayrshire and Arran. I wanted to go back to Mr McMahon's point about short-termism and needing a culture change, and just wanted to say about the demography, which I didn't get an opportunity to mention, was in terms of looking at the demography right across the life course. In North Ayrshire, for example, the biggest group of people migrating are the 16 to 29-year-olds. North, South and East Ayrshire are all sort of projected to shrink in the short term, the next 10 years, in terms of their population, their young population, which brings the issue of the dependency ratio and informal care. I don't know if informal care is something that should be looked at in terms of stopping costs rising, in terms of long-term care for older people. OECD did a big study on the level of the European GDP that informal or family care provides, and it's 20 to 36% of European GDP that informal care accounts for. And clearly there are other policy issues about if we can get young people to stay in Ayrshire and Arran, that we'll have a more balanced, not an ageing population. If we have an ageing population, we'll have a stagnating population. The dependency ratio will be huge. We modelled some dependency ratios of, if you just arbitrarily take all 50 to 60-year-olds and project that to 2035 for them looking after over 75-year-olds. In South Ayrshire, we ran out of young people, obviously because South Ayrshire's got the highest proportion of over 75s. The increase of, say, over 85-year-olds between 2010 and 2035 in Ayrshire and Arran is 110%. They'll account for 10% of the population. And I think if we don't try and do things like graduate recruitment programmes, offer housing that's easily accessible to young people to get their first home, to have families start up, to keep the population balanced, so it's like multiple policies to look at the ageing population and maintain it in the more rural areas? If that's
employment's a key issue as well, of course, because obviously if there are fewer job opportunities in North Ayrshire or indeed other parts of Scotland, then people move to where there are opportunities, and that it creates an imbalance of its own. Now, I've got no one here who's actually got their name down to speak, and we're close to the end of our time, so I just want to give everyone an opportunity to make any final comments if they so wish. It's not compulsory by any manner of means, but if anyone want to make any final points, please, now's your chance to grab my attention and let me know if you want to make any. Michael?
Just two very quick points. I think on Catriona's point about joined-up work between housing and health, my experience in Edinburgh is that it works relatively well when dealing with people coming out of hospital. Allocations process gives people who have medical or health needs absolute top priority. We've got a joint housing register which gives people access to housing associations and council homes. It works pretty well in terms of what stock we do have in the social housing sector is prioritised for people coming out of that route. The fundamental problem is the lack of new stock coming through. And the second point I want to make is that there's always a danger in these debates that we focus on there's not enough money. I think one of the things that's incumbent on public servants and officials is the importance of looking at new ways of funding things. And certainly our experience in, I suppose, pushing the boat out on new housing development in the last couple of years has led us to, by adopting other forms of tenure, more private sector funding, moving our approvals from about 500 new homes to 1,500 new homes. That's the council and housing associations. But it's meant the council putting in prudential borrowing, it's meant more private sector funding, it's meant moving to mid-market rent, slightly higher rent model, but it works and creates a significant strategic impact in delivering the new homes, the cheaper heat homes and the more flexible needs homes. So it's the new funding models and the risks that we have to take in doing that.
Thank you, Jean.
And I don't...
Well, that's really helpful at this stage.
It's really, I think, it seems to me that there's a number of academic studies, and we haven't cracked, I don't think, as a public sector or as a government, how we best use university and academic research that happens. There are across Scotland 2 or 3 examples where there have been practical pilots, if you like, and also the new economic forum, which is about how we best use money and how we take things to a much more local level. And I just kind of have to leave all these thoughts, but sometimes the solution lies in the street or in kind of fairly small communities. And I feel that there is more and more research, and would just say that we haven't cracked how we use that. A lot of really good research sits gathering dust on shelves. Mm-hmm. And it seems to me that local authorities, health boards and so on, we need to find a way of bringing them into that integrated approach on housing too, because there are some extraordinary solutions have been found and are actively happening in some places. So it's a kind of hope at the end of it.
Hold on, Soumen was going to come in first there before you, Bob. Soumen.
2 points for me, one of which I hope ties into that. I was wanted to, for all the points we've all said, I just want to try and put something a little bit positive in as well on that point. That there's been a lot of what we've said here today, which I think is not a commonality, and it's not as if we compared notes before we walked in the room. So I think that was emblematic of there's actually a lot of work and a lot of thinking going on, along not just as reflected through the work of this committee, but whether it be NHS health boards, councils, integrated partnerships, housing, whether it be third sector, private. There's a lot of debate and discussion around, there's a lot of richness around, and people trying to tap in to what's going on and trying to do different things. There are a whole series of demands upon that, but we are trying to get into it because it's difficult. This isn't a unique Scotland thing, this is across the UK and Western Europe, so this is difficult stuff, taking on your point about solutions. What's clear is that there are no magic bullets, but we are all working on it. I think the second point is just to pick up on Catriona's element in terms of the integrated health and care partnerships have the potential to be a game changer. And really just a position I'd want to underline, which we've got in our submission, I said earlier, is that from Western Bartonshire perspective, the most effective vehicle for doing that then is to make sure that all health and social care services across cradle to the grave effectively within the community are within the purview of those partnerships. They're not just effectively older people or adult partnerships, they cover children as well.
Thanks, Convener. I was going to say that the point that Dean Erskine makes absolutely right. Interestingly, when we did the SROI on adaptations in very sheltered housing, we asked David Bell to validate it, and he looked at it in quite some detail and worked with us on it. And that's something we routinely do in terms of trying to validate the work that we're doing and see whether or not there is a bigger picture there, if you like. I mean, I think in terms of the comments that have been made this morning, I think there is a lot of good work that's going on. I think there's a lot of collaborative work going on. I think where I would maybe part company a little bit is that I still have the view, as someone having spent most of my career in local government, that there's too much navel-gazing and that the public agencies speak to themselves perhaps more than speaking to the customer base. And the challenge for all of us is to focus more on the customer, what their needs are, and feed that back. And if that were the case, would that change how we deliver services? And you may say, I would say it, wouldn't I? But I'd still say housing is fundamental to a caring and safe society, should be at the planning table. And when I say that, it's not with a public sector hat on, it's with a private sector hat as well, because a big part of the housing solution for us going forward has to involve the private sector, and they're not around the table at the moment. So when I say housing, I mean housing in its broadest sense. It has to be part of that debate. And I think the challenge for us as a society is to use the resources we've got in a different way and change the attitude, the culture, the perception of how we do it.
Thank you very much, Bob. And on that point, I'd like to draw this session to a close. I'd like to thank all witnesses for their contributions and indeed committee members. And at the start of the meeting, the committee agreed to take the next two items in private. I therefore like to close the public meeting to allow the official report and the public to leave. So we'll have a natural break for members and we'll be back at 11:10.